really shapes the way we think them through. So a lot of us suffer from the cultural bias against people who have addictions and other problems, and then we want to lump them into a standardized treatment model. And it turns out that the standardized treatment model doesn't work. And in tobacco use, the standardized treatment model, this is well established, is that the doctor asks the patient, are you ready to quit smoking? Do you believe you're ready to change? This is the stages of change theory. About, on average, 6% say yes, and the other 94% say no. The 6% who say yes get medical treatment for smoking cessation, and the other 94%, they don't get anything at all. They get rejected. So I apologize in advance, because this talk was designed to be projected, and it has some slides associated with it. I'd gladly send the slide set to you, but I am going to use my little computer to cue me in to how I can alter my comments so that you can get the gist of what I'm saying without the slides. You just have to imagine the slides. Oh, no, thank you. Okay. So the first question I want to do is explore the distinction between the harm of smoking and the harm of vaping. But this is about vaping. You've seen some of the controversy around electronic cigarettes. It's hard to avoid it now. And obviously there's some legislation, that touches on this issue. But we know that tobacco causes 520,000 excess deaths per year. It's well understood in terms of its pathophysiology, how it causes death and disease. We've been studying it for decades. There are billions of users, and when we compare that to e-cigarettes or vaping, there are no reported diseases or conditions associated with that. And this is very hard to say that there's nothing out there. But just go Google syndromes associated with electronic cigarettes, and you'll find nothing. Now, we have concerns about electronic cigarettes, but the absence of some of the conditions has to suggest that there's less going on. And that's our whole point about harm reduction. Instead of simply categorizing people as yes or no, on or off, we have to recognize that there's a continuum of responses, and vaping represents something that's less harmful. Now, one of the things that makes vaping really problematic is that there's 800 different brands and thousands of different flavors. But in aggregate, we can make some initial conclusions about what the problems really are. Right? That is that we know that the chemical constituents in vapor are substantially less than the chemical constituents of cigarette smoke. How much less? 90 to 95% less. Now, some of you may take an extreme precautionary principle and say you don't want any poison. But you recognize, just as with alcohol, if you say no, what happens to someone who has an addictive disorder? They enter a defiant mode. They'll say, no, I really want some. So having some is maybe important. The some that you want to give them, most probably is nicotine, and you don't want to give them the tar. So the other 95, the constituents of tobacco smoke, which cause disease, are certainly the tar and other chemical compounds. Whereas nicotine, contrary to what you'll hear from the FDA this week again, is relatively harmless. Nicotine, you can give it in a patch, you can give it to people in as a gum. It's an FDA-approved medication. Today, within 2 years, it'll be illegal to give most popularly available forms of nicotine to people unless they pass a complex set of regulations. Let me go back and talk about electronic cigarettes. They've been out for decades. We don't know that much about them, to be honest. I mean, there's been thousands of papers published, and I can say with confidence that the level of toxins in e-cigarettes are less. Are there no toxins in e-cigarettes? true. There are some toxins. But if we can accept a graded approach to understanding the problem, then we can be pretty far along in understanding how we can help people. So you need to make your own decisions, and you can go out to the literature and review the various websites and so on. The consensus among scientists is that there are less toxins in e-cigarettes. However, no one is saying that they're harmless. Are we willing to take a public policy position that it's okay to take something that's less harmful? So that's an important distinction. A lot of people want to debate the issue, and I'm happy when they do debate the issue, as to whether or not e-cigarettes actually help people quit smoking. Kind of early in the discussion about e-cigarettes, if you read the papers and line them up, they uniform, and they study different e-cigarettes in different countries, in different populations, including populations of people who don't want to change. It's a very important thing. And when you give e-cigarettes to people who don't want to change, you know what happens? Some of them change. About 20% of those people are able to quit smoking, and 30% of those people who remain on e-cigarettes are able to reduce the amount of cigarettes that they smoke. And so when you look at all the studies, in aggregate, it's not a powerful set of studies, but every one of them points in the right direction. Again, I encourage people, I have a chart where I summarize it, and it's linked to bibliography and so on, but if you look at the data, you say every one of these studies lines up in the correct direction. And the Cochrane review process, that's a meta-analysis process that's sponsored by international professional societies. They say that the evidence says that smoking cessation and smoking harm reduction is supported by e-cigarettes. However, the evidence is not strong. The evidence is strong enough for England to take a public policy position promoting the use of electronic cigarettes for smoking cessation and for tobacco harm reduction. And for they're even dispensing e-cigarettes to help people who are unable to quit smoking by other means to proceed with their own smoking cessation or as a fallback position, harm reduction strategy. Part of the confusion that comes up in electronic cigarettes is that in the earlier versions of electronic cigarettes, people were not getting enough nicotine. And that's important to understand that people smoke in order to maintain a constant level of nicotine. Nicotine is an antidepressant. People are self-medicating with nicotine. All right? Cognition is improved in people who have attention deficit disorder and schizophrenia if they take their nicotine. You can understand where people who have depression, schizophrenia, ADHD want to take nicotine so they can feel normal. Well, what's the barrier? What are we struggling with here when we get to the issues of harm reduction? Why have we not done what England has done? And I think the reason is that we're a very conservative country in this regard in terms of public policy. We don't want to promote things that have unintended consequences. Right? And the unintended consequence that most people are concerned about are the effect of nicotine on youth. Promoting nicotine to young people is a bad idea. It's now illegal to sell electronic cigarettes. Actually, just in August, they made illegal the sale of nicotine to minors. But before that, minors could buy nicotine through electronic cigarettes. Minors have not been able to purchase cigarettes for decades. But there's a concern, a legitimate one, about young people adopting nicotine acquisition by any means. Young brains are vulnerable. We want to limit access to drugs by young people. Let them be able to make their own decisions about the behavior. It turns out that drugs that people that have early in life change their brains. And it makes it more difficult to change. So we want to delay the onset of adoption. We're concerned about unknown health effects of electronic cigarettes. We're worried that people who use these cigarettes may be getting things that we don't know about. And I've given you a very short summary of a very large literature and said that less harmful. But what if there's something in the e-cigarette device itself that presents a condition? So people want to take a conservative view of that, right? Another concern on the part of people in discussing e-cigarettes is the renormalization of smoking. We have changed culturally the landscape of smoking from 45% of the population to 15% over the last 15 years. That's extraordinary. One of the concerns there is that. However, my focus is on the 42 million smokers in the United States. The people who, on average, will live 10 years less. If you're a person with a mental illness, like I characterized before, on average, they will live 25 years less. So a harm reduction strategy, when applied to a large population, 40 million smokers, would have a profoundly positive health effect. So I think one of the themes that we're raising here is that if we increase our threshold of awareness for how we can help a population, we'll realize that harm reduction strategies can become a very valuable set of concepts that can be applied to help people meet those needs. Thank you.
I wasn't going to do it. Shamed and stigmatized into whatever. Thank you all for coming today and spending your lunch hour with us for this exciting briefing. It's always a pleasure for me because I do work in a silo. I work on drug policy, and so to hear about the impact of harm reduction on alcohol and tobacco and sex, it's really interesting for me to be able to bring all of these worlds together as well and share some of the best practices, but also some of the biggest challenges, because you'll hear some of the themes echoed that you've already heard. I want to go ahead and also thank R Street for inviting me and the Open Society Policy Center and Open Society Foundations for co-sponsoring this event. And we have, I don't know if this is even on. So I'm going to talk a little bit about the opioid crisis, which I know a lot of people in this room have been thinking about, working on, and hearing about. But I'm going to also make sure that it translates into the broader drug policy context, because I think a lot of times we participate in what we like to call sort of drug exceptionalism. For a long time it's been marijuana. Well, marijuana is different than the other drugs, so it's okay if we think about better ways to deal with marijuana. Medical marijuana is okay, taxing and regulating is okay, but still we're scared of the other drugs. And what we've seen in the last couple of years is a new form of drug exceptionalism take hold, and that's the new opiate crisis. And I think that this has made us lose sight of some of the other challenges that we continue to have with drugs, particularly there's no conversation going on right now about stimulants and stimulant abuse. So the conversation around methamphetamine, which was very active about 10 years ago, has all but died off. Their stimulant treatment protocols are outdated and should be updated. So I just want to say there are a couple of things that we have to parking lot because they're a different briefing. And that would be one of them. But I do want to use the opiate crisis as a way to illustrate the best practices of harm reduction and what harm reduction really means in the drug context. So first, let me give you a little bit of history around harm reduction. It first evolved in the late 1980s in Europe as a response to the HIV and hepatitis C transmission epidemics among injection drug users. Basically, by the time we knew what caused HIV and full-blown AIDS, Congress rushed to criminalize many of the treatment protocols that would have impacted or greatly reduced the infection. So that meant Congress created a ban on federal funds to be used in drug treatment provision services like syringe exchange programs. So these programs provide sterile syringes to individuals who inject drugs, and again, don't emphasize the abstinence-only approach that you heard about, right? That the reality is individuals who are struggling with a substance abuse issue, substance use disorder, really can't arrive at sobriety overnight, if at all. And so making sure that addressing individuals' needs meant taking on this philosophy of reducing the harms of the drug use, but really looking through a public health lens that included increasing access to treatment, fact-based research on drug education, injury prevention, and one that also recognized the intersectionality of socioeconomic status, race, past and present trauma, and sex-based violence and discrimination. Overall, harm reduction, as the European model started and has been adopted by countries around the world, including the United States, has sought to really reduce the harms associated with drug use, but also to reduce the harms associated with drug laws, because as you heard, there are many times unintended consequences that emerge and that we're not ready, that we haven't thought through, and are tough on crime. Drug policies of the last 40 years really created public health crises in communities, but also within prisons, because what we know now is that prisons create sort of a microcosm environment, and what's happening in the real world is also happening, but at a higher level in a prison setting. And so there's still drug use, there's still unsafe sex happening, and there's very limited access to even first aid care for minor cuts and injuries. And so what we know is that many times the laws that have been put in place to improve public safety have really directly undermined public health. And so the new public health focused drug policy that's been underway in a really strong bipartisan fashion for the last about 5 years, most recently though in the last 2, really have been marrying both the need to increase public safety while also increasing public health, and not trading one for the other. So there are a number of interventions that you all might have heard about that come under the sort of rubric of harm reduction for drug policy. So the first I'll talk about really quickly, no facilities exist in the United States, but there are safer injection facilities or safer drug consumption spaces. It's a mouthful. But these are places where individuals can come and inject or smoke drugs under the supervision of health practitioners, nurses, for instance, who could administer naloxone after or as signs of an overdose begin to take hold. They can also help with wound care, which is a huge, huge problem because you have individuals injecting in the same spots, many times using unsterile equipment. And so it provides a hygienic atmosphere with access also to treatment referrals for individuals. It's sort of a hub where individuals who are typically underserved by many of our sort of community agencies or opportunities are able to go and start to navigate some of those spaces, housing, treatment referrals, medical care, those kinds of things. Another intervention that you've probably heard a lot about is medication-assisted therapy, and so you might be familiar with methadone or buprenorphine, for instance. Those are 2 of the most common medications used for opiate replacement therapies, and so these medications can be prescribed to individuals so that they can, just like with the naltrexone, reduce or stop their drug use. So methadone particularly is widely accepted and available in most countries. It can relieve withdrawal symptoms in just 24 to 36 hours. And it's been available since 1967. Methadone, again, can be used as a maintenance medication or as a detox program, but it has to be done with medical provider and in the auspices of a treatment, a comprehensive treatment plan for that individual. In fact, NIDA actually has identified methadone maintenance as one of the most cost-effective treatments, which saves typically $3 to $4 for every dollar spent in treatment costs. Buprenorphine is also available by prescription, which I mentioned, and it's designed to ease withdrawal symptoms. But there is still difficulty for accessing buprenorphine at the level that individuals need it in the States. So although there was a patient cap that was recently lifted, there's still a very small number of providers who are able to prescribe buprenorphine in the States. And then I mentioned naloxone, which is the opiate antidote, sort of. It blocks the opioid receptor, so it reduces overdose mortality, though it only lasts about 20 to 90 minutes. So it's really meant to be used in the instant that an individual is having an opiate-induced overdose, but provides a window for them to get to a hospital to get emergency services. So ambulances carry this, police officers carry this in some jurisdictions, and there's a greater emphasis on making sure that lay people through programs like syringe exchange programs can have access to naloxone, so that, you know, if David and I were sharing drugs and he starts to exhibit overdose symptoms, I can go to my bag and get the naloxone and call for emergency services. There's an extension of the naloxone laws. That's a Good Samaritan law that a lot of jurisdictions have passed also, which is really critical because the Good Samaritan laws also act as an immunization to law enforcement so that you will not be arrested for drug paraphernalia, drug possession on the scene of a crime or the scene of an offense, or gosh, I'm using bad language, scene of an incident. So that, you know, a lot of people do not call because they're afraid to get involved with the authorities. And so many people just seem to put people in a recovery position and then jet because they're afraid. So this Good Samaritan law, when widely publicized by health departments like here in the DC, at the DC Health Department and City Council, really can be instructive in helping to boost the response time for individuals who are suffering an overdose. So I talked a little bit about syringe exchange programs, and I think probably many of you sitting in this room have worked somewhat on lifting or modifying recently the federal ban that was in place that prevented syringe exchange programs in the states from receiving existing federal prevention dollars, HIV and hepatitis C prevention dollars. I think it's really critical to mention that this ban was always in place except for 1 year in 2010 when it was removed and then replaced the following year. So money that year didn't even get to the states to make a dent. And unfortunately, we saw what happened when that, you know, Kentucky, Indiana, Ohio, the HIV outbreak rates have been really epidemic proportions. And so what we've seen is, since the modification was lifted by, really, I mean, a large share of the credit should go to Representative or Chairman Hal Rogers on the House side, because this for a long time was a real challenge for him to get behind, and eventually was able to come to terms with the need, particularly in his state, to really help individuals. And so you saw this too in Indiana. I mentioned these astronomical HIV rates, but how do you say it? The POTUS, are we saying that? The Vice President-elect? Have you seen this written out like that? Anyway, Governor Pence actually also green-lit an emergency ban repeal in the state of Indiana last year because of the HIV rates. And so this is a real opportunity now for Republicans and Democrats to come together and continue to ensure access to these critical funds, because it's going to take a long time to undo the damage that's been done in these communities, not just urban communities where we've seen the war on drugs play out for the last couple of decades, but really in rural and suburban communities where we're seeing this opiate crisis really manifesting. And so the U.S. actually has more than 100 syringe exchange programs operating. I think the number actually is 225, but I would encourage you to check out the Coalition for Syringe Access, that website, to get up-to-date information. I think one other important thing to think about when we're talking about harm reduction is not just about medical interventions, but also I mentioned that harm reduction is also a philosophy that seeks to undo the damage caused by the impact of drug laws as well. And so many advocates in harm reduction really feel like police reform is also a harm reduction strategy, because many times communities who have come into contact with hyper drug law policing have had real challenges, not just with use of force, but also with mass incarceration, and so destabilizing those communities. And so reducing exposure to police through decriminalizing simple possession of drugs, through creating diversion programs where law enforcement are able to divert individuals to community-based treatment as opposed to make arrests. Those kinds of programs are really critical to making sure that individuals can be in community and maintain their health without the compromising environment of a jail or prison. I see we're running low on time, so I can stop there and be happy to take some questions.